This is Jeff Caulfield. I'm the chairman of the Ethics Committee at Grandview Hospital, and today I'll be talking to you about medical ethics and end-of-life decisions. The GDAHA wants me to talk to you about what the Ethics Committee does, as well as the Patient Self-Determination Act, which is part of the Ohio DNR law. We'll be talking about establishing level of care orders, especially how you do that in EPIC, and who decides when the patient cannot. And lastly, we'll talk about how to get help with tough cases. Each hospital has a bioethics advisory committee, and they have four main functions. The first is to provide consultations regarding difficult cases. We also review policies for the hospital on end-of-life care, establishing DNR orders, brain death, etc. We provide education to residents and medical students, and we also provide mentoring to the other members of the Ethics Committee. Ethics committees have certain legal, financial, and quality aspects that they help the hospitals with. First, we provide some legal protection to the hospital if we have a policy and you follow the policy as it's set up. There are certain financial and regulatory agency requirements for ethics committees, such as those from the Joint Commission. There is also quality indicators that we can impact regarding pain management, organ donation, as well as patient and family satisfaction surveys. There is significant need for healthcare worker and public education, as evidenced by the fact that in Oregon, which has had many years of experience with physician orders on life-sustaining treatments, still 10% of the forms in Oregon are invalid because they're improperly completed or there's a lack of physician signature or date. This need for education is also evidenced by a study on resuscitation of residents with do not resuscitate orders in nursing homes. In this study from Becker and Yergin in pre-hospital emergency care, they measured the frequency of EMS calls to nursing homes for patients who had DNR orders. Out of 392 calls, 139 of the patients had a DNR order, or 35%. Of those patients, 29 ended up getting a resuscitation attempted, which was 21% of patients who had a DNR order. This obviously demonstrates that there's still a significant problem. The state of Ohio tried to address this by establishing a do not resuscitate policy called the Patient Self-Determination Act back in 1990. This law creates a portable DNR, which includes an official form, an ID bracelet, and a wallet card to help patients identify themselves as having a pre-existing order to not have a resuscitation. The law also describes components of CPR as well as stipulates what would not be done if the patient has a DNR order. Lastly, it did provide protection from liability if you in the emergency room or in the hospital were to follow the instructions on the DNR form and not resuscitate a patient. This next slide demonstrates the Ohio DNR form. You'll see that it has a couple of blocks on the top for DNR-CC, which would be comfort care only, and DNR-CC arrest, meaning that you would continue care and only establish the comfort care part of the policy if the patient actually went into cardiac arrest. There's also two other boxes at the bottom, one that says this is a DNR order, and the other would say that the patient has a living will with now a qualifying condition, and you need to check one of those boxes as well, and then fill in your name and the date. It's also worth pointing out that living wills generally apply to persistent vegetative state, and many of them do not address do not resuscitate orders or wishes for the patients. Many families think they do, but you do need to be careful and take a look at each one that comes through. The newer versions of the Ohio Living Will do have a provision for establishing DNR arrest or DNR comfort care. Regarding the DNR and DNR-CC, the old terminology was just do not resuscitate. The new terminology is DNR-CC arrest. This means that we would provide comfort care when the end comes, but until the patient goes into cardiac arrest, all other treatment could continue, including dialysis, antibiotics, even treatment in the ICU if necessary. DNR-CC means comfort care measures only are to be given, and when you establish this, we also need to have a discussion with the patient and family as to whether certain measures could be stopped, such as dialysis, ventilator support, lab draws, blood pressure support medicines, antibiotics, etc. There is a procedure for placing limits on resuscitative efforts at each hospital. These should include writing in your progress note that you had the discussion with the patient or patient's family and what decisions were made. Orders will need to be established in Epic, and we'll show you this in the next couple of slides. You should then fill out a copy of the Ohio DNR form so that the patient will be able to take that with them once they get out of the hospital. And I recommend that at the end of each daily progress note, you include a note that says the patient is DNR, or if there's other limits on their care, such as a Jehovah's Witness who wouldn't want blood transfusions, that you also include this on the last line of your progress note. This will help the cross-covering residents, when they're called to see the patient, to see that there is a previous level of care established. In this slide, we have the computer screen that you would see in the Premier network for a patient who has an established DNR. You'll notice that the menu bar near the top is completely red, and this is the visual identifier that this patient has a DNR order, again in the Premier network. Our next slide shows the establishment of DNR for the patients in the Kettering network. Here you'll see that in that same menu bar, which is white, there is a little square that's yellow that it says that the patient has a DNR CCA order established. Each hospital has a process for establishing DNR in Epic. The Kettering network, I believe, has an order set. As you can see, I have it in my favorites here. The other option would just be to write DNR as an order, and it will pull up a box where you can then check certain other blocks to clarify specifically what limits there will be on the patient's care. I also recommend that when you do have these discussions, in addition to documenting them in your progress note regarding the decisions made, that you also make sure that you enter DNR into the patient's past medical history. As you can see on this slide, we have typed in DNR, and there is a past medical history identifier that will show up. Then in the comment section to the right, you can clarify if there are specific limits on care that the patient wants. The advantage of having it in the past medical history in the computer is that it will then show up in Epic on subsequent admissions. Once you have the DNR in the past medical history, you should also click on the box to add that to the problem list. That gives us another way of making sure that that order is recognized the next time the patient comes into the hospital. When we're having discussions regarding the patient's care, and in particular decisions on end of life or on limitations to the care that will be provided, there is an order in terms of who has the power to make the decisions. We obviously want the patient to be able to tell us what they want if they can. If the patient's not able to tell us, then we need to use a spokesperson. If there isn't a spokesperson, then we look for any caregivers who would be able to tell us about the patient's life and might give us clues as to what they would want done in a particular situation. If there aren't any spokespersons, the physicians on the case may invoke futility, and each hospital has a policy for this. And if the physicians are unable or unwilling to make that decision, then an ethics committee consult may be necessary to help to clarify who should be the spokesperson and what kind of treatment should be provided. By law and by convention, the spouse is the spokesperson unless there is a compelling reason to suspect they don't have the best interest of the patient at heart. Adult children would be the next in line, and parents would be next. This next slide provides a state-by-state summary of the priority for the spokespersons, and this does vary some by state, as you can see. Another important aspect when discussing end-of-life care with patients is the Ohio 48-hour waiting period. Modified Uniform Rights of the Terminally Ill Act provides guidance regarding withdrawal of life support in cases where the patient is terminal, has severe brain injury, or is in a persistent vegetative state. The physicians and networks have some protection from liability if the 48-hour waiting period is observed. When establishing the procedure for withdrawing a patient from life support, we must begin by making an effort to contact priority individuals, the spokespersons who would help to make the decision. The patient should then be made do not resuscitate. As part of the discussion, we should include talking about the 48-hour waiting period and make note of the time that this discussion takes place. If there's consensus among the decision makers, then we can proceed with withdrawal of the patient from life support at the end of the 48-hour waiting period. If the waiting period requirement is causing conflict, obtain an ethics consultation to help manage the patient, provide education, and facilitate getting good patient and family satisfaction. If there is not consensus among the decision makers, or if there is a priority individual who can't be contacted, or if one of the family members raises an objection, then a 48-hour waiting period is mandated by Ohio law. The purpose of the waiting period is really to give the objecting member time to raise their objection. They then must go to probate court within 3 days after they have raised the objection in order to request that the spokesperson for the patient be changed. Interestingly, the 48-hour waiting period is not recognized uniformly in Ohio, and many physicians are not aware of it, which is part of the reason for including this discussion today. The key when you're having these discussions will be to include early discussions about the 48-hour waiting period with families before the decision is made to withdraw, so that the families won't be surprised once we do reach a decision to withdraw their loved one from life support. You may want to include a discussion about withdrawal at the earliest indication of severe brain injury, so we can choose to start the waiting period while confirmatory testing proceeds. And interestingly, the law is also silent on withholding or withdrawing dialysis, antibiotics, and pressors. There are exceptions to the 48-hour waiting period. The first is when a patient is declared brain dead. In that case, life support can be withdrawn within a reasonable amount of time after the family is notified. There is no need to wait 48 hours, and there is some flexibility for the family to be able to gather before the patient is withdrawn. The second situation would be when a patient is awake but on life support and requests withdrawal. If there aren't any concerns regarding the patient's state of mind, withdrawal may proceed, and again, the waiting period can be waived. The third exception would be in a case where a patient comes into the emergency room and is intubated, and after the resuscitation, they're found to have a valid DNR designation. In those cases, we may elect to withdraw the patient or might wait the 48 hours as the laws governing these designations conflict. To summarize, each hospital has an ethics committee. If you need to get in touch with us, the nursing supervisors or the risk managers at each hospital would be able to help with making contact. You could talk to your program chairperson, as they would know who the members of the ethics committees are. If all else fails, write an order for an ethics consult. And even if that's not the right way to do it, you can guarantee that people will come running to help you to identify the right way to get this done. You do want to discuss any ethics consult with your attending if this is appropriate. And if you have any questions or more interest, feel free to attend a committee meeting to learn more.